You might want to speak up, Dan.
In 2014 respiratory care. All right, so I have no disclosures. The objectives I would like to cover for this are understanding the clinical need for accurate height measurement and what the limitations are that we get in determining height and other anthropometric measurements. And for alternative methods, is there a good correlation, or are we going to have to change our practice totally? So who really needs accurate height in the clinical setting? Nutrition needs it. They need it for both RE, they need it for creatinine clearance, and a lot of their dietary calculations are based on height, as well as determination of BMI. We use it for lung protective ventilation. Pulmonary function uses it for predictive values. Drug dosing, such as Velitri and other medications. And we also use it for body surface area determination, not only in burns, but we use it in ECMO as well. So height really is very important statistic in clinical medicine. But problems that we have obtaining accurate measurements could be the injury to the patient. The patient may not be able to move, they may be contracted. It could be poor measurement technique due to the deteriorating clinical status of the patient, and you just can't get to the patient at the time. Convenience, do you have the equipment necessary to measure the height? What if the patient is a double amputee? How do you determine their height for lung protective strategies? And another one is mass casualties and forensics. Although we don't have to deal with the forensics part, we do have mass casualties at times, so how can you rapidly determine height for your patients? In forensics, this is if there were a mass casualty and they're trying to identify bodies, they can use long bone determination. So the gold standard is the stadiometer. It's a familiar piece of equipment in most doctors' offices. And you have the patient standing as straight as possible, and then you have a crossbar going over a measuring bar, and that will get the crown. Now the issue here is we're wearing shoes in this picture, and so it really should be in bare feet for this, but this is just a pretty good demonstration of the technique. What do we do when we need to get the height but the patient can't stand? We have alternative methods. We have the heel to crown method that is used mostly on our ventilated patients here with the tape measure. We can also use arm span, and if you can't do total arm span, you can use a half arm span, which is also known as a demi span, and I'll show you that. A newer technique for us at least is determining ulnar length. If you measure the ulnar from the olecranon process to the spine process in your wrist, you can actually base that determined height for that. Length of the tibia has been used in other areas, and in pediatrics, foot length was once described to determine height, and it correlates fairly well. So in review, to do the heel to crown, it really should be with the patient as flat as possible, and you want to have the feet upright, and so you measure from the heel to the crown of the head, and that will give you the patient's height. That correlates fairly well with the measured height of the stadiometer, but although there's not compression on the spine, it may be off by up to 1.5 inches. Now, we could also use the arm length. If you have from middle fingertip to middle fingertip, that almost correlates within 1 inch of the patient's actual height. So that's a good way to do it, but you have to have the arms very straight, and the patient needs to be quite cooperative. You could also use a demi-span, which is easier if you have a patient who is sedated. So you can just stretch the arm out, go from the middle finger down to the sternal notch, and then you can double that, and that will give you the same factor as if you did the arm span. Now, here is the technique to, well, this is a good illustration for measuring the rate, the ulnar. And it's, there's a little drawing superimposed on this arm. You can use calipers, but you can also use a tape measure as well. And most recent articles are using the tape measure. But the calipers will give you accuracy within 1 millimeter. Okay. So we also have the knee length. If you have a patient who is unable to stand for whatever reason, you can measure from the heel up to the patella and place that into an equation that has been validated for various genders and ethnic backgrounds, and that will give you a height, and it's pretty stable. So, in using height measurement has been utilized a lot in dietary, as I've mentioned, and in Britain they have the Malnutrition Universal Screening Tool, the MUST, which will show how to measure both ulnar and BMI using arm statistics, and they have little lookup tables over here. So based on the patient's age and gender, you can actually figure out what their height and predicted body weight should be. Now this is an ulnar lookup table, also from the MUST as well, and we have less than 65 years male and greater than 65 years male, and same for the female. Now, as we age, we do get shorter, and we may have some loss in bone. So this is why you have the two cutoffs, and they're pretty accurate. So how do these alternative methods compare? Are they interchangeable? And what's the complexity? Obviously, we don't walk around carrying calipers around. And how much is attributed to practitioner error? So here is an article that was from the International Journal of Morphology, and it's from 2010. It was a study done in Sri Lanka with 258 medical students, and they looked at both the left and the right ulnar measurements of the medical students. The medical students ranged from 20 to 23 years of age, and so it was a pretty tight age grouping. And they found that in this particular population, you could use either the left or the right ulnar, regardless of hand dominance. And there was correlation between male and female. So here is all the data for the males, ulnar length and total height based on stadiometer. And here is females, ulnar length with stadiometer height as well. And you'll notice that as the scatter plot, it's pretty tightly grouped, and there is some correlation to it. So they are able to predict height. And based on the slope of those two lines, they were able to come up with a predictive equation using regression to calculate height for this population, for both males and female. And then they were able to take that data and combine it, and they then found a combined equation for this. So just in case they needed forensics, they could determine height based on that, and would give a pretty good idea of what the final height of the person was. Now, this is a relatively old study. It's from 1968, but it was very interesting in how it was done. This looks at foot length of infants or children up to 6 years of age, and they wanted to see if there was a change in if there was a way to predict height with just a footprint. So they took 683 African children under 6 years of age, or at least 6 years of age, and they did a footprint. The footprints were then sent to another investigator who measured them from the tip of the great toe down to the base of the heel, and they were able to calculate the height based on a predictive equation that they developed. And it showed that based on the three ethnic backgrounds of the children, they were able to get pretty tight correlation. You know, the closer this is to 1, that means the higher the correlation. So this is all greater than 9 right here, except this one. And they were able to find a decent predictive equation for height based just on the footprint of the child. And this, the idea for this was if you have disease where the patient's contracted or you are unable to extend the limbs for whatever reason, you can still use just the length of the foot as height. And here are the correlations for both boys and girls, and you'll notice that it's pretty accurate for predicting. So as the foot grows, obviously the child will grow, and they can use this for this small population, and they had pretty good correlation. Okay, and so ultimately the end of this study was they were trying to predict a growth chart for these kids, and they broke it down, and you'll notice it's again the correlation other than the first year for females is pretty high, and even here I would say it's relatively high. It's still good, and as the child grows, the foot's going to grow in proportion. So this was an alternative method for judging nutrition, medical interventions, and such. And there was no follow-up after this study was done. So I was looking for that as well. So they had a significant level of correlation between height and foot length, and that was between the 3 groups of African children. In the very young child, it could be very invaluable because you could just do a quick footprint, which is very easy to do. Anybody can be taught how to do it, and then you would have a record, so you could actually keep that record and trend the patient's growth. And the only problem was it was limited to very small population variation. It was one clinic in Africa, and they only had about 700 children participate. Okay. This is the article I would really like to spend the remainder of the time on, and this was from Respiratory Care this past July, and it was a comparison of usual and alternative methods to measure height for mechanically ventilated patients. And height is used for lung protective ventilation, as we are all very familiar with. And their hypothesis was inaccuracy in determining height could lead to lung entry because we are using smaller tidal volumes based on height calculations. And the medical record may be incomplete. It could just be subject to the cut and paste phenomena, as it was mentioned in the editorial accompanying this paper. It could be self-reported, or it could be reported by a patient family member, or it could just be a pretty good guess from anybody. And are there alternative methods to obtain a height at the bedside that we can correlate with the stadiometer? So this was a prospective study of elective cardiac surgery patients. They had 100 patients, more men than female, and rough age was 66 years, plus minus about 9 years. And prior to admission to the hospital, the patients were measured in various ways for height. They used the stadiometer, and that was considered to be the reference method. So for all patients who could stand, they had them stand, they measured it, and they were comparing everything against this value. There were 2 alternative methods. They used the leg length method, and they also used the ulnar method. They used an equation for both the leg length, and they also used the Bain lookup table that I had shown earlier in this to determine height. Okay. And for leg length, they actually used the Chumlier equation, which is a well-known equation in the nutrition circles, because this physician is more focused on the nutritional aspects of healthcare, and look at low leg length as a function of height, and this is the generic equation, not based on any particular ethnic background. So certain ethnicities will have shorter stature, and they would have different long bone length as well. Okay, so for the post-operative period, once the patient had their surgery and they were admitted to the ICU, within 10 minutes of admission after the patient was stabilized, they would have either the respiratory therapist or the nurse determine what the height was. And they did this by two methods. One, they said, how tall do you think this patient is? And then they gave them a tape measure and had them measure the tape. Both the nurse and the therapist were blinded to the previous measurements. Okay, so here's what they are, and these are the diagrams from the paper itself. So the first is the eyeball method, and just guess, and then they would use a tape measure to do the heel to crown. And that was compared with the previous measures. And you'll notice here is the reference measure from the stadiometer. I don't know if you can see that, but that's 165.8. Okay, and then we have for visual estimation, just a guess, it's 169 for the tape measure, 168 for the Chumlea method, and the Ulmer method is 167. So the correlation is actually very high. And you'll notice that there is a little difference between here, and that's due to the variation. Okay, so some of this is actually practitioner variation, but the means are actually pretty tight here, and most errors were within 5% of the reference angle. Okay, and here the measurements in a graph, and so this is the reference. And so this was estimation based on the reference, and you'll notice it's a scatter plot, but it's still pretty tightly grouped. And then we have the low leg method, and it's very tightly grouped, and so there is quite a bit of correlation. Okay. And then with the tape measure, there is a little bit more practitioner style or technique involved rather than with the lower leg method. And as well, when we get to the forearm method, we notice that there's it's also technique dependent as well. So if we look at the difference between the reference method and the height that we have, and then they're plotted into a scatter plot, you'll notice that visual estimation is probably as good as a guess. I mean, it is a guess. And this is what it would show. But when using the low leg method, it's still pretty tight, and the correlation is within usually within the first standard deviation. Now the measuring tape method, it's still the correlation is still pretty good, but I mean it's more spread out. But the forearm and the Chumlea method, where we're using actual bony processes of the patient, it's still a very tight correlation, and it works rather well. So the conclusion is we can use these two alternative methods to determine height of the patient. So again, looking at the differences, this is predicted body weight based on the height, and you'll notice that we have up to a 10% variation with even small height discrimination. So this is one of the reasons determining height is very important for critically ill patients, because a 10% change could be, the difference between 8 mLs and 10 mLs per kilo, or could also be a caloric intake or different drug dosing. Okay, so impact on height measurement on Title I. So the authors of this study actually recalculated predicted body weight and then looked. Oh, what was that? So the authors of this study recalculated predicted body weight and tidal volumes based on the various methods, and noticed that there was a bit of a spread between that of the height using the reference method and the height using the alternative methods as well. And the big issue is, you know, the shorter the patient was, the greater the error. So actually, if you're a tall patient, you can use just about any particular method. But if you're shorter than average, if you're average to below average in height, you're going to have the greater amount of error in there. So the limitations and conclusions of this study were the Chumlea method was not used for bedridden patients, because it really, to do it properly, you have to have the patient sitting up. But they modified it, and by having an assistant hold the leg while somebody else would actually measure the lower leg length. All equations were previously determined for specific populations, but then they used this for a more general population. They didn't find any correction factors. And current methodology may result in improperly set tidal volume, as they showed. When the reference height is not available, we can use these alternative methods, and it could provide adequate insight into how the patient's being treated. Okay, there was an editorial that accompanied this paper, and it was very interesting. One of the criticisms of this paper really is inter-rater variability was not determined, and it was also not graded. And I agree, because the greater number of people they had looking at this, you can have different styles. They didn't describe exactly how to use the tape measure, and so people were just saying, oh, okay, well, I'll measure it from this point to this point. In preparing for the editorial, the authors of the editorial did a very quick study where they had a medical student get measured twice a day by 10 different nurses, just to see if they, using alternative techniques. And they noticed that the guess was actually had a smaller standard deviation than using tape measurements. So that really shows that there is a specific technique that we need to adhere to with tape measurement. And accurate measurement is very clinically important, and care needs to be taken in determining what the height is. Okay, just to strengthen this, I am moving height over to body surface area, and determining body surface area for a patient has been a problematic issue, not only in burns, but also throughout clinical medicine, because people would not, just straight lines and flat planes. And so one of the big issues is they would like to create an accurate body surface measurement based on a three-dimensional model. Now, models tend to be based on one ethnic background. Usually, it's very difficult to get enough people together. So what they were trying to do was use 3D scanners for people and then recalculate body surface area based on a database. This would improve body surface area measurement, and in burn situations, it would actually decrease the fluid creep, or the excessive amount of fluid being given for resuscitation during the first 24 hours of burn care. Okay, so here's an illustration of how it is. We have a mannequin here, and these two are 3D scanners. And with the mannequin being there, those scanners would actually rotate, very similar to how a CT scanner would work. But you can actually stand in this particular one. This is a radial scanner, and it will come up with a three-dimensional image. The only problem areas for this were really the hands, and so they constructed a 3D hand scanner. And this is just a model of the scanner. So you had 4 high-resolution scanners that would actually measure the hand, because the hand is actually very problematic in determining for body surface area. Okay, this is a Lund-Browder chart, and this is really the gold standard for determining body surface area. It is age-specific, so as a person ages, the body proportions are going to change. Children have a larger surface of the head compared with adults. And every portion of the body is given a surface area size, and then you can just determine how much damage. Now this is the modified Lund-Browder illustration based on the body scan, and you'll notice that some of the changes are actually pretty dramatic. Like the right hand is given 2.5%, and that's still the same, but the trunk will also change. If the patient is obese, you can actually determine how much more body surface area the abdomen or the lower body would have. So this is another way of determining anthropometric data for a patient. And you could also determine height very accurate here with this, and this is why I've included this particular illustration. Okay, so having an accurate measurement really does have an effect on treatment. It would allow the patient to be over-resuscitated or under-resuscitated, which could have dramatic effects on the course of the injury. Multiple factors need to be considered, whether the patient's excessively tall or short, if they're obese, or if they're have a lot of lean body mass. And patients present with many obstacles which prevent us from getting reliable measurements, such as neuromuscular disease, injury, prior surgery, trauma, and all that. And so, although we do try to do our best, sometimes the patient themselves will hinder. Okay. Any questions and comments?
Yeah, did you have a you make available the various equations for the different body parts measured?
Mm-hmm.
What was the variation of tidal volume? I couldn't quite read it, but it's significant, wasn't it?
Yeah, it was pretty significant. Yeah, I couldn't read it either.
Yeah, about like 20 mLs?
Yeah. Yeah, it could go up as much as 40 mLs for one group. So.
Were the measurements like skewed, when they used the tape measure, was it skewed one way or the other?
They didn't look at inter-operator variability, which was one of the criticisms of the paper. So yes, it was, but they did not look into how much.
But we couldn't tell if they were all high or all low.
No, they weren't. And if you look at the standard deviations, I mean, the estimation was, we tend to estimate high. And the tape measure was pretty equal on each side.
I was impressed with the eyeball method.
Yeah,
It seemed pretty accurate.
I was too. I was very impressed with that.
I just tested her. I tested her like 10 minutes ago. She failed.
Sorry, Ryan.
By 9.
I look up the height.
So can you send out a spreadsheet to everybody, so if they want to use owner life,
Sure.
they can do that?
Yep.
You don't have to draw it on the patient.
No, that was just a really good picture.
Yeah, it
I
was
able
a
to find.
let's see how accurate it was.
And I have done it on a few patients when we were doing the esophageal balloon studies, and it was within the ballpark.
Yeah, the other thing we have to remember, and actually I'm in favor of using the honor method. I think it is simpler to do, and there is, as you showed, evidence to support that. However, we need to remember that in the ARGNet study, that's that's not what they used, but the seminal study that we base all this on used a tape measure and measured from heel to ground. So we are sort of one step removed from what was done in the original study. And I'll share a little anecdote. Some of you get tired of hearing my stories probably, but I was over on Under 6 a few weeks ago, and there was a patient who had been admitted a few hours before, and the height wasn't in on our flow sheet yet, so I know now, but didn't know then where they store the tape measures over on Under 6. But I asked the nurse if there was a tape measure available, and she went into the drawer and handed me one that was about this long. So I thought, this doesn't help, measure heel to ground. But then I thought of the Honor method, and it worked perfect for that.
Thank you.
For some at least theoretical reason why the ventilator does these things better than what exists, then I wouldn't even consider, that mode or that adjunct to ventilate somebody. These two, although we have virtually no experience with NAVA, we do have a fair amount of experience with PAV. And this is a whole lecture in itself talking about these as I've done before. My own biases, these are the modes of the future. This is how I think we will be ventilating patients as time goes on, where the patient is the controller of the process as opposed to the clinician being the controller of the process. I believe as time goes on, we're going to learn more and more about the importance of patient-ventilator synchrony, and that modes that ensure synchrony as these two do compared to traditional modes will end up to be the approaches that are used on a much more regular basis under patients that we mechanically ventilate. So, tomorrow, what can you expect on a mechanical ventilator? Well, first of all, we have problems, as you well know, interfacing our ventilators into the data management system of the institution. We have trouble with interfacing them with the monitors, etc. That will change. I think you'll see within the next 5 years that all technology at the bedside in the ICU will feed into some computer-based system, because everybody's going to be mandated to have computerized charting, and we need to have appropriate enunciation of alarm systems. I see no reason why we can't have one ventilator that does all this. There are ventilators now available outside the United States that do this, and this right now. Now, how good they are, I haven't had an opportunity to work with them, but clearly our ventilators do all the above. If you want to take the Servo-I, which has a lengthy battery, we can do transport, with the Servo-I as well as doing the rest. There is no reason why we should have a multitude of different ventilators for doing different tasks. It's just a matter of the companies providing more compact pieces of equipment. I mean, you see now that the home mechanical ventilators for doing BiPAP or CPAP, we just talked to people from Philips now about some more units that we want to, get to replace some of the STD-30s, and they're, 6 inches by 6 inches by 6 inches, the whole ventilator. So they should be able to produce an ICU ventilator where the screen is easily disconnected and stay in the room while you transport the patient instead of looking for another transport ventilator. It's better for the patient, it's better for you, it's much less expensive than choosing a whole herd of different mechanical ventilators. As far as the feasibility of doing children with an adult ventilator, as you know, we use the Servo-I's up in the neonatal unit based on ours and others' assessment of the capability of those devices in lung models ventilating the equivalent of a neonatal patient. We compared the Babylog, and it was a Babylog Gold, the top of the line that we got from the company, to the GE Care Station, the Avita XL, the PV840, the Servo-I, and the Avia. And we looked at all of these parameters associated with gas delivery. 0 line here represents equivalence. So if there was nothing on either side, it would mean that each of these ventilators were exactly equivalent in their performance to the baby lung. Anything on this side showed superiority to the baby lung. Everything on this side showed superiority to the ICU ventilator. And as you can see, responsiveness, ability to deliver gas, were all in favor of the ICU ventilators. So I would expect the first thing we're going to see is the elimination of neonatal ventilators. I mean, we have no problem managing our neonatal population with an adult mechanical ventilator. And we could probably use the H40s as well as using the Servo-I. But the Servo-I did better at this point in time, was compensate for leaks and had less problems with alarms. New algorithms that are now available at the H40, that if we purchased it, probably would be now equivalent to the Servo-I for use in pediatric patients. This is data we abstracted at the Society of Critical Care Medicine meeting, comparing all of these ventilators in a lung model and their ability to compensate for leaks and deliver non-invasive ventilation. What we did was add 6 scenarios of increasing leak, 6 scenarios of decreasing leaks that were applied in a random manner. These represent the total number of breaths for the ventilator to reestablish the ventilatory pattern that existed before the leak was changed. And in many cases, the ventilators were able to accommodate things on the next breath or 2 breaths afterwards. In the decreasing leaks, very rapidly, it's easier for a ventilator to readjust to a decreasing leak than it is to an increasing leak. But look at the Servo-I and look at the H40 compared to these 4, which are all non-invasive ventilators. It's hard to say there's really any significant difference between the function of any of these ventilators. The care station did poor. This is without any adjustment. This was, we went in and made some adjustments in the sensitivity and in the termination criteria, and it did better, but without doing that, it did really poorly. These we set up with baseline leak, and we didn't touch them after that, and we went up to leaks of 37 liters per minute. So we have a number of ventilators that can function as well as the non-invasive ventilator, which is why we use the H40s in the EW or on different ICUs to do non-invasive ventilation, because the data implies that that ventilator can function as well as the V60. In the future, manufacturers are clearly trying to match that, and every one of these ventilators that we have on the market will be able to do non-invasive ventilation as well as an ICU ventilator. ARDSNet protocol was published, come on Arnie, you're an ARDSNet man, 2000.
Yeah.
Or 2001, 2000 or 2001. There is no ventilator right now that has that algorithm integrated into the function of the ventilator. There's no ventilator right now that allows you to select tidal volume in ml per kilo. Even though it's over 10 years now that we know that we should be using small tidal volumes, we should be managing patients in lung protective methodology. None of the ventilators have done that. We could sit down and we could come up as a group with approaches to do all of these things and have them programmed into our mechanical ventilator. And have you then, when you came to manage a patient in a certain category, go to that program, make it easier for you to select modes, to set up, etc. Now we're in a little different situation here than in many hospitals in the United States, and clearly many hospitals throughout the world. You guys know how to do this. You go to hospitals other places, and that's not true, particularly hospitals in the third world, where people have very little education regarding mechanical ventilation, and there is clearly lack of understanding on how to mechanically ventilate patients. I would expect that ventilators of the future will have these algorithms built into them. You'll be able to adjust various settings but somebody who is inexperienced would be able to go to the ARDS approach and with a couple, adjustments, apply that immediately to the patient, or just COPD or asthma or whatever the case may be. This is just to reemphasize the importance. I don't know if I showed you guys this graphic before. To reemphasize the importance of the small tidal volume. This is lung volume versus body weight. These are, as you can see, different mammals. All mammals are scaled exactly the same way when it comes to lung volume versus body size and tidal volume. And you'll notice we're all on this line, which represents the tidal volume of 6.3 ml per kilo. So during resting, right now, nobody who looks too stressed, your tidal volumes are all right around 6.3 ml per kilo. If you stressed, obviously your tidal volume will go up, but under normal resting basilar conditions, this is what your tidal volume is, and this is the percent of your body weight that is your lung, whether you're a whale, or you're a bat, or you're a human. So that 6.0 ml per kilo that's been used by the ARSNet and discussed at many levels is based on sound, basic science, literature. That's what we do on a normal basis. So it seems we should be ventilating patients at that setting. How rapidly do you respond to alarms? Pretty slowly. As you hear alarms in the ICU, nobody moves. Unless if you look at the enunciator, unless it says, that the patient is in arrest or the patient is disconnected, nobody even moves. Why? Because it's a false positive. Now, I think that is a result of manufacturers not wanting to put the time and effort into developing smarter alarms. If we could come up with an algorithm that would eliminate a lot of those problem alarms. Information versus data. If I look at any of these ventilators, they give you maybe 10, 20, 30 different pieces of data that are just scattered there. You have to try to integrate that data and make sense out of it. How many different variables can you see at one time and integrate in a reasonable pattern and interpret that to make a decision? The psychologist would tell you about 4 to 6, depending upon who you are and your skill at doing it. You surely cannot look at all the variables that come up on a ventilator. And most of the time, what you do is you select your favorites and you don't even look at the rest of them. They just don't even exist. You look at 3 or 4 things that you've chosen as the important variables, and that's all you look at. Decision support. I don't think we necessarily need it here, but there are places where when the ventilator does something screwy, we should have information that says this could be A, B, C, or D, and if it is, you should do A, B, C, or D in order to correct it, and that's not available today. If we just looked at high pressure alarm, going back to smart alarms for a second, if I had these 3 scenarios and gave you them, you would identify 3 different levels of seriousness of the problem. A single breath, that high pressure alarm once in a while, pressure increasing each breath over a short period of time, or pressure increasing gradually over hours. They represent to you very different scenarios and very different urgencies in which to respond to them. If you can do that, I can program the ventilator to identify the same 3 different responses as you would. What I would expect is with the periodic, you've got some water in the tubing, some secretions. Periodically, you're seeing the pressure go up. Not a big deal. Surely you need to correct it, but it's not an emergency. Gradual change in resistance, the slow increase in pressure over hours means you've got a gradual change in resistance or compliance. Something to address, but not an emergency situation. But the increase in pressure over a short period of time, 2 breaths, as you all know, that's a pneumothorax, or high probability that's what's a pneumothorax. This is something we need to respond to immediately. And ventilators should be able to identify that. I mean, why do we need to have a persistent alarm just because we hit the high pressure, once on a given breath and require you to come to the bedside to readjust things in order to eliminate that alarm, as is the case with some mechanical ventilators. This, I think, will change because of all the pressure that's being put on manufacturers to do it. Providing information as opposed to data, why don't we see more information presented graphically to give us an idea of what goes on? We can easily correlate different variables and look at things from a graphic perspective. It gives us an idea of the change over time and whether or not we need to do something, or if it's not an issue. Asynchrony is becoming, I think, a more and more important issue. You cannot look at the waveforms and pick out all of these different potential types of asynchrony very easily. You can record the waveforms, put them on a computer, and sit there and slowly assess it. But when that waveform goes by at the rate that the patient is being mechanically ventilated, it is difficult to pick up all of these. But I can program that ventilator to identify each one of these asynchronies, to tell me how many I have per minute, and to figure out what the percentage of breaths are asynchronous versus the total number of breaths. We should have this information available to us so that we can better manage patients who are breathing in an assisted mode of mechanical ventilation.
You think we'll be able to save, how the monitors save every waveform until, it
There's no
seems like
reason
they
why
should
it
be able
can't.
to do that too, so you
Absolutely.
can go back at.
You may not be able to go back for, a month, but you should be able to go back for days, and reconstruct that information and take a look at what's going on. There are groups out there who are working on this. I work with people in Barcelona that they've got algorithms that can identify all those asynchronies on an ongoing basis, and provide you information to the frequency of each one of them, at any given period of time, every half hour, every minute, whatever you think is appropriate. I think you're going to see more the ventilator making adjustments to the way gas is delivered. Now, I spent a lot of time with many of you in orientation talking about, dealing with rise time and termination criteria and peak flow settings and inspiratory time settings to try to minimize asynchrony. You can do that, but how many minutes of the day do you stand by the ventilator and make those adjustments? Not that many, not to a single patient. The ventilator should be able to recognize those issues and automatically make those adjustments themselves, because it creates a huge problem, for patients when they're asynchronous. I realize that the emphasis has not been there on asynchrony, but these two papers published, the last few years, there's another one just published by the group I made reference to in Barcelona, and there's other groups that are looking at asynchrony, and all of them seem to come up with the same conclusion, that patients who are asynchronous have a much longer period of time on the mechanical ventilator. Now, these are not randomized, so I can't say that asynchrony caused this, but there seems to be a strong association with length of mechanical ventilation and asynchrony. That is something we should be paying attention to a much greater level, and the ventilator company should be doing everything possible to try to minimize asynchrony in our approach to mechanically ventilated patients. So this is what I see, the future ventilator looking like. Decision support available, information, things being organized to a much greater extent, smart alarms being available, programs in the ventilator to allow you to ventilate patients in different categories much easier than we do today. The other thing that should be there, I should be able to hit that screen and come up with the clinical user's manual that tells me how a particular aspect of the ventilator works. How many times has somebody asked you about how does this mode or that mode work on this ventilator? And since you don't use it on a regular basis, you probably can't describe the finite points about it. Well, why should the ventilator have that available so that you can just pop it up and you both can read it, in relationship to whatever the question is? That's not available today on any ventilator that I'm aware of. So at least in the time that I've been around, it's pretty phenomenal. You know, if I go from the ventilators that I first used in the mid-1960s, what's available today, the change is just incredible. Change today is occurring more exponentially than it did previously because of the frequency with which we can get things published and computers. I mean, before publication used to take years sometimes before it got out there and available. Now, things turn around very quickly. People are able to share information to a much greater level than they ever had been previously. And to me, this is what defined our profession, mechanical ventilation. This is what defined critical care. And I see them both growing and developing much more so in the future. And this next generation, this would be the term that I would use to define it, that ventilators will be smart. Now, whenever I say that, and I speak to a group of respiratory therapists, people start squirming in their chairs because the implication of that is that they will become unnecessary. I think it's just the opposite. You're going to have to know a hell of a lot more about the ventilator when it has all these features in it, and who's going to know when to apply them, how to set them, other than you. So this does not imply in any way that you won't be necessary. I actually believe it will make you much more necessary because of the complexity that this adds to a mechanical ventilator. So the future from mechanical ventilation perspective, I think, is very exciting. And I'll stop there,
Diaphragmatic pacing, and these patients that they've done, a few of these patients here, where typically the patient comes for Spaulding, has the pacer implanted in the OR here, and then goes back to the Spaulding. So we don't ever even see the patients. But now they are beginning to discuss diaphragm pacing for patients with ALS. And in fact, the ALS clinic here may get involved in doing diaphragmatic pacing in patients with ALS. So how it works is that unlike spinal cord injury, where I think the pacemaker is usually placed high in the phrenic nerve, here the pacemaker is placed at near the insertion of the phrenic nerve into the diaphragm. This will not work in ALS patients who have high motor neuron involvement. Excuse me, I said it backwards. This will not work in patients that have low motor neuron involvement. So if the motor neurons in ALS are affecting the lower motor neuron of the phrenic nerve, then you can stimulate the phrenic nerve, but nothing's going to happen. So this is only going to work if the disease process is primarily upper motor neuron. So this gets implanted bilaterally near the insertion of the phrenic nerves into the diaphragm, and then this actually goes through the skin, and here's the controller, which controls the stimulation of the diaphragm. So here is a video describing that.
In healthy individuals, the brain would normally tell the diaphragm to contract through the phrenic nerves that move from the brain to the diaphragm. However, when someone develops Lou Gehrig's disease, also known as ALS, that communication declines over time.
Patients with ALS develop chronic hypoventilation. That occurs because their diaphragm, the major muscle for breathing, is getting weaker from the disease. They can have problems with carbon dioxide buildup because they're not breathing enough. They can have problems sleeping at night because their diaphragm isn't working as well. The diaphragm pacing system in clinical studies has shown improved survival by 16 months over standard therapies.
That's pretty good, 16
But not only does it improve survival, as the diaphragm gets stronger with use of this during that time period, they have a better quality of life because they actually can breathe better. So it can help in the quality of life, which is key for these patients.
The Neurex diaphragm pacing system is implanted in a minimally invasive outpatient procedure. Doctors insert electrodes attached to a small external battery pack that stimulates the muscle and phrenic nerves to cause the contraction of the diaphragm.
So this is intended to actually complement non-invasive ventilation and not take the place of non-invasive ventilation. So these patients will still be on BiPAP, but they will have this in addition to BiPAP. And if the program gets up and rolling over the next 6 months or so, as they expect that it will, we're going to end up seeing some of these patients. The procedure is an outpatient procedure, but if the patient needs to get admitted for other reasons, they're going to come in with their BiPAP machine as well as with this little box. So we're going to have to talk about, when the time comes, how we can sort of ramp up our skills related to this and so forth. Now, the other thing that has been described in the literature, I only have one or two more slides, I think. So the other thing that has been described in the literature is extubating patients with neuromuscular disease back to non-invasive ventilation. And this is a paper that was published about a year ago, where they looked at a number of patients, I forget how many, actually you can do the math, it's like 150 or so patients who were intubated because of neuromuscular disease. And then rather than tracheing the patient, which would be our usual approach when we can't wean these patients off the ventilator, to extubate them to non-invasive ventilation. And this group actually reported a lot of success doing that. And you can see that for some of the patients, they were on mouthpiece ventilation, as we already talked about. This patient is on a flanged mouthpiece device. I don't even know if you can still buy these flanged devices. This patient's on an oronasal mask and so forth. So just because a patient with neuromuscular disease gets intubated doesn't necessarily mean that they then need to get trach. We may be able to manage them by extubating them to non-invasive ventilation and the cough assist. And in fact, this group reported very good success for doing that. So then in summary, there are a number of neuromuscular diseases, both acute and chronic, that have respiratory muscle involvement. And as you know, the neuromuscular disease clinic is very active here. You can think of all of the patients that we see that get admitted who have neuromuscular disease, and there are a lot more who are out there who have not been admitted. Mechanical ventilation, both invasive and non-invasive, and airway clearance are life prolonging in these patients, and we have good evidence now to support that. And many of these patients can be adequately managed with a combination of non-invasive ventilation and cough assist. And in fact, when we end up tracheing these patients, it really becomes a big deal for the patient and the family and so forth. So that's it. And CNSs are already in the loop and supportive. A couple of others just haven't seen this yet. I'm sure they will be supportive. I'd be surprised if they were not. Well, the other thing is, where will this go? So this will go in we'll keep this in the blue book. So there's a lot of discussion about it. Whether it go in the gray charts, blue charts, blue book, whatever. So it's going to go in our book, and then after 2 hours, the charge therapist can just collect them and get them back to me. Okay?
Okay.
All right.
Are you done?
I'm done.
It's a wrap.